All right. Hello, wonderful students. This is the chapter on vital signs. Vital signs are indicators of physiologic function and reflect the health status of the individual. Assessing vital signs as part of a nursing assessment is an extremely important component in all healthcare settings. Here are the learning objectives for this chapter. Please take a moment to review each one of these. If you can speak to these and apply these to your nursing practice, then you have accomplished your learning for this chapter. Vital signs. So here we go. We have vital signs and the ranges for normal, healthy adults, right? The vital signs that we monitor are temperature, pulse, respirations, blood pressure, and pain. Pain is considered the fifth vital sign as it's monitored very closely and can have an effect on every one of those other vital signs, right? Specifically, respirations, pulse, and blood pressure. Pain can definitely impact them. The normal ranges listed on this slide are for a healthy adult. Nurses assess vital signs and compare findings with accepted normal values, as well as the patient's usual patterns in a wide variety of situations. We often refer to the patient's usual patterns as their baseline, okay? Please see your fundamentals book for more information on age-related changes to normal vital signs. It's very important you know that information. We will discuss it further in detail too, but please refer to your book now so you can become familiar with the different types of vital signs that change with ages. When to assess vital signs. Appropriate times to measure vital signs include, but are not limited to, the following: screenings at health fairs and clinics, assessing a patient's vital signs in their home, upon admission to a healthcare setting, whether that's at the hospital or SNF or ALF or hospice or wherever, right? When medications are given that affect cardiac rate and rhythm, before and after invasive diagnostic and or surgical procedures. Of course, we do them in every emergency situation, right? Again, that doesn't list all of them, but that gives you a good idea of when we would do vital signs. Remember, nurses obtain vital signs as often as necessary for the patient's condition so that we can assess their progress and new onset of symptoms and so forth, right? So we got to do it as frequently as we need to do it, right? And that's what the state board will hold you accountable to. You know, it doesn't say you got to go in every hour or every 15 minutes, right? Usually. Now, I will say there are very specific criteria for different roles. Like in the PACU, after the surgical procedure, we have a very detailed, mandated assessment schedule, and you're going to learn that in block 2, right? Because surgery and OR is operative as part of block 2. So you will learn that every 15 minutes times 1 hour, and then so you'll learn all of that. But generally, as a nurse, you're held to the standards of you need to assess your patient as frequently as their condition warrants, right, to keep them safe. Does that make sense? Okay, prioritizing assessment of vital signs and adapting to those results are a primary function of our nursing responsibility, right? So again, us prioritizing, us doing our assessment of the vital signs, and of course adapting to whatever those results are, and then either getting additional orders or whatever that may look like. That is our responsibility. That's our primary, right, responsibility. Frequency of assessments should be based on the patient's medical diagnoses, their comorbidities, the type of treatments they're receiving. It could be the patient's level of severity or maybe the complexity of their illness, right? There's a lot of variables that go into it. Vital signs provides a means to identify patients who may be at risk for either deterioration or maybe they're at risk for adverse reactions or events. And why we prioritize that and while we do these assessments, right, the whole point is to give the nurses time to respond to these changes that are happening so that we can minimize the harm that they're going to cause to the patient, right, and keep the patient as safe as we possibly can. Again, please see your fundamental book in this chapter because there's a lot of really valuable information in there about assessing vital signs. In the hospital, vital signs are usually taken every 4 hours. But again, for post-op patients, there's very specific regiment of vital signs. So my floor did them every 15 minutes for the first hour. Then it was every 30 minutes for the next 2 hours, and then every hour for the next 4. Okay. Another time to assess vital signs is after medicating. For example, if your patient has a fever and you give them Tylenol, you will want to reassess if the Tylenol was effective or not within a half an hour to 45 minutes, right? So you go back and you just reassess whether or not it relieved their pain. And if it didn't, then you can contact the prescriber and see what they would recommend, right? Same thing when administering blood pressure medications for high blood pressure. First of all, if you're given a blood pressure medication that's going to lower the blood pressure, you want to make sure you take a vital sign, a BP and heart rate before you give them that medication, right? And then you want to go back in within, again, 30 to 45 minutes to see if the blood pressure has come down, right? Otherwise, you're going to notify the prescriber if it did not, so you can get further direction on whether they want to increase the dose, get a new med altogether, whatever that looks like, right? It's good practice to always take a set of vital signs after administering any type of medications to see if they achieve the desired effect, right? This way, the nurse can ensure that the patient has not had any adverse reactions as well, or any allergic reactions as well, or maybe even fluid volume overload, right? So some meds can cause additional stress on the heart. And so if a patient has any type of cardiac issues or other types of issues, we just want to make sure we're following up to make sure it hasn't caused any kind of, adverse reactions, allergic reactions, or even fluid volume overload, etc., right? Your goal is to keep your patient safe at all times. Keep in mind, you can take a set of vital signs at any time you feel you need that data, right? And vital signs really tells you what's going on inside the body with your main organs, right? And so I will be honest, I do take a lot of vital signs because I want to see where my patients are at throughout the day. I probably take more than I actually need, and it is always highly recommended you do more than less, right? And also, if you're calling the prescriber, you better make sure you always have a current, and I mean like in the last 10 minutes, current set of vitals before you call that prescriber. Types of fevers. All right, so we definitely need to know the different types of fevers. Most fevers, unless extremely high, in other words, above 40 degrees Celsius or 104 Fahrenheit, are not harmful. In fact, they are beneficial in many ways, right? Including destruction of disease-causing microorganisms, those pathogens we talked about in our other recording. Increase susceptibility of disease-causing microorganisms to anti-infective agents, as well as an enhanced response by our immune system, right? It provides all of those things. However, when fever is equal to or greater than 41 degrees Celsius or 106 Fahrenheit, it is referred to as hyperpyrexia, and it's a medical emergency. The body must be cooled down rapidly in these cases to prevent permanent brain damage. And it's important to be aware of a high fever or fever that is not relieved by medications or interventions, especially, let me make this clear, especially in a post-op patient, right? Because post-op patients, due to the meds that they're receiving, are automatically going to be in that higher risk of having hyperpyrexia. So we're going to watch them closely. And this needs to be reported to the surgeon like immediately, because coming out of surgery, they're already at a much higher risk for infection, right? So we need to keep them in the loop. Here we go. These are different types of thermometers that we use in the hospital, SNF, ALFs, home health, all that stuff, right? So A is an electronic and or digital thermometer. B is a tympanic membrane thermometer. C is a disposable thermometer for measuring an oral temperature. So the dots on that that you can see will change color to indicate what the temperature is. And then finally, D is a temporal artery thermometer. Here are the normal temperatures for healthy adults. Health facility policies and procedures often specify the site to be used for assessing patients' temperature. However, the nurse is expected to choose an appropriate alternate site and the proper equipment based on the patient's condition, the facility policy, as well as the doctor's orders, right? The medical orders, sorry. Factors affecting site selection include the patient's age, the state of consciousness. Are they alert and oriented ×4, or are they unconscious, right? The amount of pain they're in will definitely affect the site you'll choose. And other care treatments, like are they receiving oxygen, and all of those things. If a temperature reading is obtained from a site other than oral, it is very important to document the site and the measurement along with the results to ensure accurate comparison of data. As you can see, the normals, right, depending upon where you're measuring the temp, right? So you want to make sure that you list, if it's not an oral temp, that you list what type of temperature it was, so that the nurse who's looking at that, or the doctors, all the healthcare people, can know that it is taken in a different part of the body, and therefore they know they're comparing apples to apples, right? Okay, all core temperatures, which are rectal temperatures, must be done by an RN where I work, because it's considered invasive, right? And if the patient's on blood thinners, it may be contraindicated to take a core temperature. So think through those kinds of things, right? They're on blood thinners. If I were to cause an injury, right, with taking a rectal thermometer, that could be problematic with bleeding, right? So you got to think through these scenarios and decide exactly what makes most sense, right? What route makes most sense for my patient. Heat production. The primary source of heat in the body is metabolism, with heat produced as a byproduct of metabolic activities that generate energy due to the cellular functions that are happening throughout the body, right? So it makes sense that we're producing heat. Various mechanisms increase body metabolism, including hormones, exercise, right? And look at your patient. Many times patients are wrapped up in 4 to 5 warm blankets. If they haven't been having temperatures and their temperature is low grade, take the blankets off for a while and then go back and reassess them to see if it's an actual low grade temp, or was it due to the fact that they were, wrapped up heavily with blankets, right? So you're going to go back in after about, 45 minutes and reassess the patient's temperature before treating, right? The primary source of heat losses are skin. Other heat losses occur through evaporation of sweat, through warming and humidification of inspired air, as well as through elimination of our urine and feces. Okay, radiation is the diffusion or dissemination of heat by electromagnetic waves. Convection is this dissemination of heat by motion between areas of unequal density. Evaporation is the conversion of a liquid to a vapor. Conduction is the transfer of heat from one object to another object, when there's direct contact. So again, look at your fundamentals book under mechanisms of heat transfers, because it does go into examples of each of these, and you might see these on your exam in HESI, right? Fever basic definitions, you definitely need to know. I'll stop saying that. You need to know all of it, right? But sorry, nursing school, right? Oh, it's tough. Hang in there. You're doing great. You're going to do great. So again, basic fever definitions. Afebrile means literally without fever. Pyrexia means with fever or febrile. Intermittent fever means temperatures return to normal at least once every 24 hours. So when you have intermittent fevers, you'll be hot, but then you'll have at least at one point during that 24 hours, you will return, to a normal temp. Next is remittent fever, is temperature does not return to normal, and it actually fluctuates a few degrees either up or down. Sustained or continuous fevers, our temperatures usually remain above normal and with minimal variations. So they're sustained for a long period of time, or they're continuous fevers for long periods of time. Relapsing or recurrent fevers when you have a temperature returns to normal for 1 or more days, and then they'll have an uptick of 1 or more episodes of fever, right? Each of them lasting for several days, and this will relapse and reoccur. Factors affecting body temp. So the circadian system modulates metabolic heat production to generate the body temperature rhythm, which will challenge, the homotherapy, but does not abolish it. So we have individual cells do not regulate their own temperature. So it's important to remember that from A&P, right? Individual cells are not regulating their own temp, but the relationship between the circadian rhythms and metabolism at that cellular level is what we're looking at, right? And then core body temperature decreases as you age. As you get older, it becomes harder for your body to control its temperature because of the decrease in your subcutaneous tissue, right? Your fat. Thus, this leads to heat loss through the skin. That's why the elderly people get cold all the time, right? Again, therefore, a decrease in the amount of fat below the skin makes it harder to stay warm. That's why we tell the older generations, elderly patients to wear layers of clothing to keep warm, right? They can take it off if they get hot or warm, but then they do need it because they don't have that subcu tissue. Although men and women maintain an internal body temp of 98.6 degrees Fahrenheit, men typically have more muscle mass and therefore generate more heat because they're using more calories to fuel their energy for their extra muscles they have, right? So they literally produce more heat. When the heat evaporates, it warms up their skin, their clothes, the air around them, the surface of their skin, right? Therefore, men are typically warmer than women. During exercise, the heat produced in the contracting muscles causes internal body temperature to rise until the heat dissipation response. Increasingly, it's driven by, rising temperatures, and this will provide for a new balance between heat production and heat loss. So regarding the patient's state of health affecting their body temperature, there's a part of your brain called the hypothalamus, and this is what controls your body temperature, okay? So if you ever injure that part of the brain, then you will be unable to regulate body temperature, which, as most of you probably already know, that can be life-threatening and life-limiting, right? In response to an infection, in response to an illness, or some other cause, the hypothalamus may reset the body to that higher temperature, right? So that we mentioned this before earlier in this presentation, that a fever can be helpful in certain situations, right? When you get an infection, an inflammation occurs in the body when a foreign invader or a pathogen enters, right? Your body sends your white blood cells to the area where that pathogen is inside the body, and then inflammation occurs, right? Which will cause a higher temperature, right? Fever comes on, right? And then your body's able to, the body's internal thermostat is able to maintain that constant inner body temperature by pumping more blood to the skin and by increasing sweat production, right? In this way, the body is able to increase the rate of heat loss to balance the heat burden. So you can see how the hypothalamus works with the different organs in the body and the skin, right? To regulate heat loss as well as heat release and heat balance. Pulse physiology. Okay, the pulse is regulated by the autonomic nervous system, and it's done through the SA node, which we call the natural pacemaker of the heart, right? The sinoatrial node. Remember that from A&P? And remember the autonomic nervous system from A&P? Then we have the parasympathetic stimulation of the SA node happens through the vagus nerve, and that whole process decreases the patient's heart rate. The sympathetic stimulation of the SA node increases the patient's heart rate and force of contraction. So you see the sympathetic and the parasympathetic nervous systems working together to either initiate flight or fight, or rest and digest, right? So those two conditions which are taught in block 2 in detail. We will introduce them in block 1, so you do need to know the basics of them. They work together so that patients, when they need to respond to a dangerous situation or a heightened like when we call a code in the hospital, right? You need to be on point and it needs to be an alert, heightened state. Your sympathetic nervous system kicks in and causes, the blood to flow quicker, heavier, and then you're able to respond, right? And then once that fight or flight situation is over, then your parasympathetic system takes over and you can now rest, calm down, and that's when you start digesting your food again. You're able to have a bowel movement, go to urinate, and all that stuff, right? We'll talk more in class about it, but all right. Okay, peripheral pulses. So when assessing the pulse, feel or listen for a normal rate. So normal, first of all, is 60 to 100 beats in 1 minute. A pulse rate under 60 is called bradycardia, and a pulse rate over 100 is called tachycardia. So you want to assess the strength of the pulse. Is the pulse bounding? Is it weak? You also want to assess the rhythm of the pulse. So is it a regular rhythm? Boom, 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 boom. Or is it irregular? Boom, 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 right? And an irregular rhythm occurs with pauses between the beats as well as unequal intervals between beats. Rate and rhythm and amplitude are all characteristics of a peripheral pulse that we must monitor and chart on, right? And these are indicators of the effectiveness of the heart as a pump. So it literally is an indication on whether your heart's doing its job, right? Sufficiently. The volume of blood ejected with each heartbeat is what we call the stroke volume. I hope this is bringing back up memories from anatomy and physiology. What I will say is, if not, then this is when you will really want to read your books when it comes to the patho behind the disease processes, what's happening in the body, and those kinds of things. So you can truly, genuinely understand what's occurring in the body when something goes wrong, right? So we can fix it. All right, sites for detecting pulse by light palpations, right? Where do we take our pulses? Here we go. So this slide will demonstrate the areas that you as the nurse will feel for the peripheral pulses. You will note that most of these sites are in the area where there is a natural crease in the body, right? As there is with, when the artery is closest to the surface. Make sure you know the various sites, what they are called, where they are located. We will be practicing assessing these sites in the lab. When assessing these sites, if you cannot feel the pulse, you can either use a Doppler to assess the pulse. There are portable Dopplers in the hospital. Now, I will say several floors use the same Doppler. So if you can't find it, which it can be really challenging, then go look for it on other floors, right, that shares it. If the patient has a condition that is causing weak pulses, sometimes the doctors will order the pulses be assessed by a Doppler every shift. Especially if it's in the extremities and they're already compromised, right, due to chronic illnesses. The other thing I want to say about pulses is this. If you are feeling for a pulse and you don't feel one, then most likely you are occluding the pulse by pressing too hard. So what I'm going to tell you with everything that we do as a nurse, the only way to get proficient is to literally sit down and practice with as many people as you can. Okay, so we're going to do a lot of this in lab. Pulse strength. You do need to memorize this as well. I said I was going to stop saying that, didn't I? Bummer. So grade zero means there is no pulse. It's either absent or you are unable to palpate. Grade A is diminished, so it's weaker than what we expect it to be. Grade A, I said, that's hilarious. It's 1 plus or plus 1 is diminished, weaker than expected. Plus 2 means you have a normal pulse, right? It's brisk, it's expected, it's exactly how it should be. And then 3 plus, it means it's bounding, like really bounding. And trust me, we'll have, usually there's somebody, in lab when we're practicing on each other, there'll be examples at least of +1, +2, and +3, right? All right. Respirations involves ventilation, diffusion, as well as perfusion. So ventilation or breathing is the movement of air in and out of the lungs. Diffusion is the exchange of gases between the alveoli in the lungs and the circulating blood. So remember from anatomy and physiology, the alveoli is the part of your lungs where all the action happens, right? It's those grape-like clusters in the lungs. And then finally, perfusion is the exchange of gases between the tissues and our circulating blood. The rate and depth of breathing can change due to tissue demands, right? Happens all the time throughout the day. These factors include exercise, respiratory disease, cardiovascular disease, alterations in fluid balances, electrolyte imbalances, acid-base imbalances. Medications can cause this, traumas, infections, pain, emotional behavior from your patients, right? Emotion simply can cause this. So again, see your fundamentals book because there are some really cool examples in the book about factors affecting respiratory rate, depth, and movement. So take a peek at that. Respiratory diseases such as pneumonia causes impaired gas exchange, which can lead to chemoreceptors sending messages to change respiratory rates in the body, and then also other organs kicking in like your heart to compensate, right, for the lack of the lack of respiratory effort there, right? So your heart rate would go up and those kinds of things. Here are the different respiratory rates and terms. Please pause the video, make flashcards, and get this stored permanently in your memory. Blood pressure, right? So the blood pressure is the force of the moving blood against the arterial walls. We have our systolic pressure on the top and the diastolic pressure on the bottom. The systolic pressure is the maximum pressure when your left ventricle contracts and pushes the blood through the aortic valve into the aorta, right, and then out to the body. And then we have your diastolic pressure is the lowest pressure when the heart is actually resting between the beats. And then the difference between your systolic and diastolic pressures is called our pulse pressure. This should be a little bit of a reminder from anatomy and physiology, okay? Regulation of blood pressure, right? So again, we have short-term regulation is done either through the neural or nerve way or humoral or pertaining to the, the body fluids, right? And then we have our cardiac output is literally the strength of the heart's contractions, right? And we do know that your blood pressure is going to be affected, right, by the cardiac output. Absolutely. And then we have stimulation of the vagus nerve, right? So when we are entering into the parasympathetic impulses, right, when it's time to rest and digest, then our vagus nerve is stimulated and this will naturally lower the heart rate, right? And then the opposite of that, when we are suddenly in a situation where we need to respond to either a fight or flight situation, right? That's when the sympathetic nervous system kicks in and increases the heart rate so that the body can respond, use the glucose that has stored in their muscles for energy, right? So they can either run away or fight whatever situations in front of them, right? And that's just one example of many. Like I said before, we could call a code, and that definitely initiates the sympathetic response in the body, right? You're getting ready to respond accordingly, doing chest compressions or grabbing the epi or whatever your role is during that code, right? Baroreceptors in the heart and in the arterial walls help monitor the pressure and also signal the cardiovascular system of the brain, right? Renin, angiotensin, and aldosterone are the system that raises the pressure inside the body there. And again, this is just reminders from A&P. Factors affecting blood pressure, either factors that make it higher, or even factors that could lower it, right? So here on this slide are some factors that can affect your blood pressure, right? So some disease processes, definitely your psychosocial state, definitely if you're in pain or if you have a fever or if you have too much fluid on board or you're dehydrated. So fluid changes, definitely all of these affect your blood pressure up and down, right? And so what I would highly recommend you do is pause the video now, go to your chapter and read about the different examples of when your blood pressure would be varied based on your weight, your emotional state, your body position, medications, food intakes, right? Whether you're taking salt versus, all of those things. So take a look at that. Decreased blood pressure. Okay, so when we're looking at hypotension, so low blood pressure, right? That means you're typically below systolic 90 and diastolic 60, right? Many times we will see patients, this will happen as a result of some disease processes. Maybe it is certain medications are lowering a patient's blood pressure. Inability of the body to maintain a normal amount of pressure definitely could be, right? Heart failure, strokes, those kinds of things. Maybe it's due to you've got a pathogen in your body, and that infection is now causing, problems with hypotension. Sorry. You suddenly shift positions, that can definitely have a hypotensive effect in the body. When we look at orthostatic hypotension, we're literally looking at postural hypotension. And that results from an inadequate physiological or physical response to the position changes, literally, right? So it typically occurs when rising to an erect position. And we usually see an underlying connection between either dehydration or maybe blood loss, neurological problems, cardiovascular problems, endocrine problems, those kinds of things, right? And pause the video and look at the symptoms too, because you do want to be aware of why it's a safety risk when patients are hypotensive, right? That would make sense, right? That you would need to know as a nurse to keep them safe, right? Okay, equipment for assessing blood pressures. So the equipment used for assessing blood pressures is a stethoscope and a sphygmomanometer. A blood pressure cuff, Doppler, ultrasound, maybe. Many electric or automated devices are used to assess blood pressures. The Korsakoff sound, which is the first beat that you hear on the pressure, when you're taking the blood pressure. The change in beat or the last beat is the diastolic pressure. So again, the Korsakoff sound is the first beat that you will note on your gauge, right? And then the last beat is your diastolic pressure. And we're going to, of course, learn how to do this and do this in lab. These two measurements give you your blood pressure, systolic over diastolic, in a ratio form. Again, we're going to be doing it in the lab, and we're going to make it much more easier, practice lots so it gets easy over time. And again, refer to your fundamentals text and chapter to take a look at the Korsakoff sounds to learn more about these series of sounds that we listen to measure our patient's blood pressure. Okay, here are the parts of the sphygmomanometer, and we have 3 different sizes. It's really, really important you get the right size for your patient. Being too big or too small can definitely give you a false low and false high blood pressures accordingly. Of hypertension. Okay. Again, I'm going to refer you to your book, right? Because it talks about patients 18 and up, what the different types of hypertension is, right? And hypertension is a major risk factor for heart disease, and it is the most important risk factor for strokes, associated with strokes. So that's why we're all the time doing, blood pressure clinics and all kinds of things to try to diagnose hypertension, because a lot of people, 95% of the population is who has hypertension is walking around out there and don't even know it, right? Because it's a silent killer. There's no significant signs or symptoms when it's elevated. So that's why we call hypertension the silent killer, right? Very few symptoms beyond increased blood pressure. Over time, this sustained increase results in a permanent remodeling and thickening of the blood vessels, right? It damages the blood vessels. As a result, there is increased peripheral resistance as well as a backup of pressure to the organs that's affected by the vascular system, like the brain, the heart, the kidneys. So you can see over time how this remodeling and thickening causes damage to these organs, right? And again, we're going to go more into detail on this when we talk about cardiac later on in the block. Categories of antihypertensive medications. So we have antihypertensives work to reduce blood pressure in patients who have hypertension. These medications work in different ways. We have diuretics, for example, hydrochlorothiazide or furosemide. They help reduce fluid in the body, thereby reducing volume in the vessels that can cause hypertension. So you can see how there's a direct benefit there. We have beta blockers, such as metoprolol or propranolol, and they block the sympathetic stimulation and therefore reduce the heart rate, right? So beta blockers specifically will, again, reduce blood pressure, but since they block the beta cell, they will also lower the heart rate, right? Vasodilators such as hydralazine relax the blood vessels, decreasing vascular resistance, thus allowing blood flow to flow more easily, right? What's next? ACE inhibitors, such as lisinopril, work on the angiotensin-aldosterone system, and they relax the veins and arteries, which in turn lowers blood pressure. Again, you're going to get a lot more information on all of these when we do the cardiac module later on in the block. Do I want to say anything else? I don't think so for now, okay? This is a good introduction to vital signs. Again, you'll want to listen to this PowerPoint a couple of times, right? Because it's critically important. And utilize your book. Really important for this chapter. All right. Thanks. See you in class.